In this presentation, we're going to be learning how to obtain a medical history and vital signs. Viewer discretion is advised. Some slides may have visual effects that aren't always suitable for all audiences. We use the Emergency Medical Responder First on Scene for our Emergency Medical Responder course. We do not get paid to use this book, however, over the years, this course has been the easiest for our students to comprehend, therefore is why we utilize it. This work is protected by the United States copyright laws and is provided solely for the use of our instructors to teach courses and assess the student learning process. This content on the website has been made available for our instructors to copy and distribute to our students in our classes as we see necessary. All education provided is a guideline to help you learn new concepts to better treat your patients. Your local protocol supersedes any education you learned in this course. You must always review with your medical director before changing your treatment plans that are outside your local protocols. You will be able to define the following terms: auscultation, baseline vitals, blood pressure, capillary refill, chief complaint, cyanotic, diaphoresis, diastolic, jaundice, medical history, mental status, OPQRST tool, palpation, perfusion, pulse, respiration, sample history tool, sign, stethoscope, symptom, systolic, trending, vital signs, work of breathing. You will be able to explain the importance of a thorough medical history, differentiate between the sign and a symptom, describe the components of the sample history tool, and describe the components of the OPQRST assessment tool. You'll be able to state the characteristics that are obtained and measured when assessing respirations, pulse, blood pressure, skin signs, and pupils. You'll be able to describe the methods used to assess each of the 5 vital signs, and differentiate between normal and abnormal vital sign values for infant, child, and adult patients. You will be able to explain the role that monitoring vital signs plays in the overall assessment and care of the patient. Differentiate between the techniques used to assess a pulse in an infant, child, and adult patient. You'll be able to demonstrate the ability to properly obtain and accurately trend and document vital signs, and demonstrate a caring and compassionate attitude with classmates and simulated patients. In this section, you will learn how to obtain a medical history. When obtaining a medical history, it is safe to say that a good patient assessment is likely to result in a good patient care. A good patient assessment includes knowing how to ask questions and discover information that is not immediately obvious. All the information that you gather about the patient's current and previous medical condition is referred to as the patient's medical history. The first thing you must know about obtaining a patient history is the difference between a sign and a symptom. A sign is something that you can see and observe about your patient. Think of it more so like road signs. A road sign will tell you to stop. A road sign will tell you to yield or that you're going the wrong way. So if you are alert and paying attention to those different signs that that patient is showing you, it's going to show you a lot about what's going on with the patient, but it's also going to help you figure out what's going on around you. So the same applies to patient conditions. A sign can be a pale skin or rapid pulse or an open wound to the chest. Most signs are pretty obvious if you're alert and are properly trained how to look for them. So with a patient, you always want to get down at the eye level with them and make good eye contact as you begin your medical history. However, if it happens to be a psych patient or somebody who looks like they're angry, then I would, obviously look at your stance and where you're standing toward that patient, but you should always try to make good eye contact with them. Symptoms are very different and much more difficult to discover. A symptom is something that the patient feels and may complain about, and they are also something that are discovered through asking questions about what the patient is experiencing at that time. They can also be very obvious, but they can also be very subtle at the same time. One of the most common symptoms that a patient can experience is pain. Other common symptoms are nausea, dizziness, shortness of breath, chest pain possibly. So certainly you've experienced at least some type of a symptom in the past that I wouldn't be able to know. So a symptom is something that only you know. It's nothing that I can necessarily see because that would be a sign. So a symptom is something you feel or that you're complaining about. So your assessment then should be focused on gathering and documenting as many pertinent signs and symptoms as possible to ensure that your care is going down the right path and that the care that you provide for that patient is adequate to what their signs and symptoms are. In most situations, an alert patient is the best source of information. Nearly every patient encounter with an alert patient will begin with questioning them about what he or she is feeling or what happened that made them call for assistance. This is referred to as what the patient's chief complaint is. So whenever appropriate, it is best to direct your questions to the patient rather than somebody else. Unless, of course, it's a child or a very young child, then it would be usually more appropriate to interview a parent or guardian or possibly a caregiver. If the patient happens to be unresponsive, you must look for other sources for this information, including family members, bystanders, and other responders that were there prior to you, and find out what information has already been gathered. So the big thing that you want to make sure is that you're asking your questions slowly and clearly using a caring tone of voice. You want to allow for plenty of time for that patient to process what you just asked them and to respond to your question before asking another one. If needed, repeat or rephrase that question if you're just not sure. And then listen carefully to what the patient is telling you and document important details as necessary. It can be very frustrating for that patient, especially dementia patients, when an EMR doesn't listen and the patient must repeat the answers he or she has already asked for or responded to. The level of cooperation and quality of answers you receive from your patient can greatly be influenced by the rapport that you establish early on. This can also be influenced by others on scene. A simple sequence can be used for most situations and will work well for quickly establishing a good rapport with your patient. If you ask them what their name is and they tell you their name is John, but you a minute later call them Jim, they're going to start believing that you're not listening to what they're telling you. If they say that they're having chest pain and you say, so you're having shortness of breath today, you're gonna start losing trust of that patient. So keep that in mind when you're doing stuff, and always make sure that if you forget names easily, that you're writing that name down either on your glove, on a piece of paper, or something, so you always remember what their name is. One of the most common tools used for obtaining a patient medical history at all levels of the EMS is called the Sample History Tool. It is a simple acronym that consists of key reminders. So the acronym helps that guide and flow of the interview and helps you keep in mind the most important questions to ask your patient. So each letter of the sample acronym represents a specific element of your interview and should trigger specific questions related to that patient's medical history. So for instance, S is what signs and symptoms are you seeing in that patient? So remember, you're seeing a sign and you're listening to a symptom. A is allergies. Does the patient have any allergies to anything? M is medications. What medications is that patient on? P is past pertinent medical history. So what do you have from the past, or what does that patient have from the past that's linked to what's going on today? When was their last oral intake? E is going to be events leading up to that illness or injury. So if you can remember this is the key tool that we use out on medical calls, trauma calls, doesn't matter. Your sample history is that main set of, like, your baseline information almost. Okay. Next is another very commonly used tool for obtaining a deeper patient history, which is called the OPQRST tool. So just like the sample history, each letter of this tool stands for a specific word that is designated or triggered for more specific questions. So the OPQRST tool drives more of a detailed assessment related to that chief complaint that's going on today and can be very helpful in gathering additional information that the sample tool may not have had or maybe has missed. So OPQRST is commonly used for an assessment of pain or discomfort, but it can be used for other problems as well. Typically, OPQRST is going to mostly be used on the medical patient. Okay, so with the first one is O, onset. The word onset is designed to trigger the questions pertaining to what was the patient doing at the time that the pain or the symptoms began. For example, what were you doing when the pain began, or what were you doing when you first began to feel short of breath, are different questions that you might ask related to that onset. And it allows you to determine if the onset was sudden or if it came on over time. Next is P, provocation. The word provocation is designed to trigger questions pertaining to what might make pain or symptoms better or worse. So for example, does anything that you do make that pain better or worse? And does it hurt to take a deep breath, or when I push here or here or here? And then, do you get dizzy when you stand up? These are different questions that you might ask that patient that is related to the P, the provocation. Next is Q for quality. It's designed to trigger questions pertaining to what the pain or symptom actually feels like. So for example, you can ask them to describe how your pain feels. Is your pain sharp or dull? Is it steady or does it come and go? So these are some other related questions that you could ask. R is region of the body, or does it radiate anywhere? So it's triggered to ask different questions of where is that pain originating and where it might be moving to or radiating to. So some examples is, can you point with one finger where your pain is the worst? And then does that pain move or radiate to any part of your body? Another one is, do you feel any pain anywhere else besides your chest? So these are, again, some questions that relate to that region and the radiation part of it. Next is S for severity. The word severity is designed to trigger questions pertaining to how severe the pain or discomfort is. So we always use a standard 1 to 10 scale, which is typically used and presented like this. So we always ask, on a scale of 1 to 10, with 10 being the worst pain you've ever felt, how would you rate your pain right now? You can take it a step farther and ask the patient to describe that severity of pain when it first began using the same scale. So when you first noticed this pain on a scale of 1 to 10 prior to calling the ambulance, what was your pain level at? Was it at a 1 or a 5 or where was it? That will also give you that baseline of when they called, their pain may have been a 9, but now you're there and their pain is a 7. So they're getting a little bit better. And then again, once you've been with that patient a while and you provide that different 1 to 10 scale, maybe right before you get in the ambulance to transport, you could ask them again, hey, how's your pain doing on a scale of 1 to 10? Where are you sitting at now? So maybe they started out with a 9, and then when you got on scene, it was a 7, and now they're getting into the back of an ambulance, and maybe their pain's at a 4. Well, okay, so we're doing our job. What did we do? Did we give them oxygen? Did we give them nitro for chest pain? Did we give them aspirin? What was it that we gave that their pain's starting to go lower? Or is it just some anxiety that they're feeling that their pain started at a 9, when people got there it was a 7, and then now that they're being transported to the hospital, that pain level went to a 4. And that you can see happening, and that's what's called a trend, is what was it when you got there? What was it when you're done with the patient? Okay. Next is T for time. The word time is designated to trigger questions pertaining to how long that patient may have been experiencing that pain or discomfort. So a question such as, when did you first begin having that pain today, or how long have you had this pain, will usually suffice. And that's when they'd answer back like, it started at 9 o'clock this morning. You look at your watch and it's 1 o'clock. Oh, okay. So it's been happening for 3-4 hours. All right. So has it been the same over this time, or has it gotten better or worse? So you may encounter a patient who is unresponsive or unable to answer your questions about his or her condition or history. If this is the case, you must depend on family members, bystanders, other first responders. Maybe it was law enforcement that was on scene first. Maybe it was fire department that was on scene. So some different questions that you may want to ask them, because maybe the bystanders don't even know who this patient is. But you can ask them, what is the patient's name? Maybe they don't know that patient's name and they'll just tell you they don't know. But if the patient is a minor, you can ask the parents if they're present and so forth, um, what that patient's name is. The other thing is you can say, did you see what happened? So did you see if that patient fell from the ladder because they're laying on the ground? Because that is going to change what you do as a responder. If they're unresponsive and it's a medical, that's one thing. But if they're unresponsive and they're below a ladder, you're talking about a trauma call now, not a medical necessarily. But just remember that just because it's a trauma call doesn't mean it wasn't a medical first that caused the trauma, if that makes sense. But did you see what happened? If the patient fell from the ladder, did he or she appear to faint or pass out first? Or was he or she hit on the head by something that caused them to fall? Another question you can ask is, did the patient complain of anything before this had happened? Were they up on a ladder and they complained of chest pain and they passed out and fell? Or were they in their kitchen making breakfast and they complained about, oh man, I'm having some chest pain today? You may learn of different things like, yeah, they complained about chest pain at breakfast this morning, and then they got kind of nauseated and short of breath, so they decided that they were going to go, lay down for a little bit. And when I went to check on him 2 hours later, he was unresponsive. So, I mean, there's just so many different things that you could take to that next level of additional questions. And to me, I don't think asking a lot of questions is a bad thing, especially if you want to know what is actually going on with that patient. Another one is, does the patient have any known illnesses? So this might only be something that family and friends may know about them. Sometimes family doesn't know. Maybe they're here visiting and they haven't seen their family member for 2 or 3 years and they just decided to get together, and now all of a sudden their family member's having a medical condition. Family and friends might not know. So you just have to keep that in mind as well. So different things that I always ask every single patient is, do you have any previous heart conditions? Are you a diabetic? Are you allergic to anything? I've asked if they've had strokes or if there's anybody in their family that's had strokes. It just depends on which direction that the patient is complaining about their pain is different questions that I'll start to think about. And don't get caught up like you have to know all these questions right now, because honestly, you learn the questions over time, listening to other people on a call, listening to the transporting ambulance service, asking questions and so forth. And then the other one that you can ask is, does the patient take any medication that you know of? And oftentimes, knowing what medication a patient takes can actually tell you something about their past medical history. Like if they have nitro, well, then you know that they've obviously had chest pain or, possibly a heart attack previously to this. So that's something else that you need to think about. You must depend on bystanders or family members when your patient is unresponsive or unable to provide a medical history on his or her own. The other thing is, just don't be too confident that you're going to get a lot of good, adequate information. In this next section, we're going to discuss vital signs. In the context of medicine, the word vital refers to which is required for the continuation of life. In EMS, several specific signs related to the patient are commonly observed and measured. The list of signs may differ slightly from system to system, but most EMS systems include the following in their list of vital signs: mental status, respirations, pulse, blood pressure, skin signs, and pupils. It can be argued that not all of these signs are truly vital to life. such as the mental status, the pupils, and the skin signs. But the other three are truly necessary for someone to be considered living. So in a quick little overview, remember what perfusion is. It's where that adequate delivery of well-oxygenated blood and nutrients to all parts of the body and the elimination of waste products. So each of the 5 vital signs then serve as a window into the patient's perfusion status. So for instance, a patient with an abnormally slow pulse or low blood pressure may not be getting enough blood to all parts of their body. So in other words, the flow of the blood or the perfusion is compromised. Another example is a patient with breathing difficulties. He or she may not be getting enough air to adequately supply the blood with enough oxygen. So in this case, the flow of blood may be adequate, but the contents of the blood would be lacking sufficient oxygen. And one more example is someone with pale skin. He or she may be showing signs of shock. So as you learn about those different vital signs, just keep in mind your goal is to paint a complete picture for your patient, of your patient as possible. So no single vital sign should be used to drive the care that you provide. So if you take a blood pressure and the blood pressure is 110/80, does that mean that that patient is in shock? No, but if you look at their skin tone and it's pale, and you look at their pulse and it's increased, and you look at their respirations and it's increased, well, guess what? After you have a pack of vital signs that are all pushing toward the same thing, you might be able to start looking at that. Okay? So your baseline vitals, vital. It is so important to get that baseline set of vitals, which can alert you of any problems that require immediate attention once you arrive on scene. You should be taking these at regular intervals, and they can help you determine if the patient's condition is getting better, getting worse, or staying the same. So the very first vital sign that you obtain from your patient is referred to as that baseline. So that's what you got there, and that's what it started out with. Now if their blood pressure or their vitals get worse or better, depending on what you're doing. All subsequent vital signs are compared to the baseline set. So this comparison helps determine if that patient is considered stable or unstable, if they're improving or getting worse, and benefiting or not benefiting from the care that you are providing. So for example, comparing baseline vitals before and after initiating an intervention, such as administering oxygen, can give clues as to whether the oxygen is actually helping the patient or not. So then we go into our next thing, which is called trending. So it is one of those values of obtaining and documenting vital signs that can be a trend, or that it's trended. So the trending is the process of comparing multiple sets of vitals in the same patient over time. So vital signs can change for the better, or they can change for the worse, or they can remain generally the same. So each represents a trend and can provide valuable information about your patient. So you want to carefully analyze all vital signs, which can be alert you to a current or developing problem. So there's multiple different things. For an adult patient, a continuous pulse rate below 60 beats per minute or above 100 beats per minute is considered abnormal. Likewise, a respiratory rate above 30 breaths per minute or below 10 breaths per minute is considered abnormal and require interventions. However, you also have to remember that vital signs do differ from patient to patient. So what might be normal for me might not be normal for anybody else. With your patient's mental status, it can provide a valuable information about the patient's condition. It should be noted that a patient with an altered mental status should be considered unstable and in need of immediate ALS care. A patient's mental status also refers to as the level of consciousness, and you'll see these as LOC, or level of responsiveness, which is commonly evaluated by using the AVPU scale. So what is the AVPU? So the AVPU is yet another acronym that we use. So it starts out with A as alert. So This is the patient who is alert and spontaneously interacting with the environment around them. That means they're talking to you and they're answering questions. Next is V for verbal. That patient is responsive to verbal stimuli. So when you say, "Hey, Johnny," and he opens his eyes or he moans or groans, that would be considered a verbal stimuli. You're waking them up when you say their name. So this is also a patient who appears unresponsive though. So, but again, he wakes up or responds to you or speaks to you when you ask him or her a question. However, and this is the key, he or she may not provide any meaningful information. It might be moaning or groaning or grunting or whatever, but at least when you say their name, they respond in some sense. That's considered verbal stimuli. Next is pain, P for pain. The patient is responsive only to painful stimuli. This is the patient who appears unconscious and does not respond to your verbal commands. However, he or she does respond by groaning, pulling away from you when you provide some type of painful stimulus, such as maybe rubbing the sternum with your knuckles or pinching the muscle above the shoulder near the neck. If they respond to that, even if they pull away from you, that is considered painful stimuli. And then last is your unresponsive patient. This patient is unconscious, completely unresponsive, who does not offer any type of response, no matter if it's verbal, painful, does not do anything. This is when your patient is considered unresponsive. So just to do a little recap, so our baseline vitals is that first set of vital signs that we obtain. Then we have the trending, which is comparing multiple sets of vitals from the same patient over a time period. And then careful analysis of the vital signs can alert you to a current or developing problem. But do not rush to a conclusion too soon, because your next set of vitals 5 minutes later on that unstable patient might show you something totally different. So just be patient and keep doing your care for that patient. All right, next we'll talk about respiration or ventilation, which is the act or process of breathing in, which is inhaling, or breathing out, which is exhaling. So you will evaluate several characteristics when assessing a patient's respiratory rate, depth, sound, and ease. So a single respiration is one entire cycle of breathing in and out. The respiratory rate is a count of the patient's breaths, one inhalation plus exhalation, and this is classified as normal, rapid, or slow. So the characteristics of breathing that you will be assessing and measuring are the rate, the depth, the ease, and the sounds. So while you're counting respirations, note if the depth is normal, shallow, or deep. Breathing depth is normal, is said to be a good tidal volume. So if you notice if the breathing is easy or whether it appears labored or difficult, which may also indicate an increased work of breathing. So you want to listen for any abnormal sounds during the breathing, such as snoring, gurgling, gasping, or even wheezing. So if the patient is responsive, ask if he or she is having any pain while they breathe in and out. Normal breathing is quiet and effortless, and a patient who requires efforts to breathe is said to have an increased work of breathing. During your respiratory assessment, you want to grasp the patient's wrist as if you were going to count the pulse rate. Hold his or her arm firmly against his upper abdomen. And you want to do this because many patients will unknowingly alter their respiratory rate when someone is actually watching them breathe. Next, you're going to observe the patient's chest move in and out, and then listen for abnormal sounds. Next, you're going to count the number of breaths the patient takes in 15 or 30 seconds. And then to obtain that respiratory rate, what you're going to do is multiply the number of breaths in 15 seconds by 4, or the number of breaths in 30 seconds by 2. You can do the 15 seconds, however, I think it's more adequate when you at least measure them for 30 seconds and times it by 2, especially if they're having abnormal breathing. At that point, any abnormal breathing, I would just do over an entire minute, because if it's that abnormal, doing it for an entire minute is going to get you your best and most accurate rate. And then while counting the respirations, you want to notice their depth and the ease of breathing. And then record your findings by documenting the rate, the depth, and the ease. So as you can see in these figures, in A is the emergency medical responder assessing the respirations on a supine patient. So even though they look like they're checking the pulse, they're actually looking for the respiratory rate. And then in picture B is assessing the respirations with a seated patient. The presence of a pulse gives the insight into the circulatory status of the patient. So a good pulse indicates blood is moving well throughout the body. The pulse is nothing more than a remote heartbeat, and it is caused when the artery lies close to the skin, pulsates as the pressure increases and decreases with each heartbeat. So there's several pulse points that can be used. So first is the carotid, which is in the neck, then the femoral, which is in the groin, and these pulses are referred to as central pulses because they are in close proximity to the heart. Then you have the brachial, which is in the upper arm, and the radial, which is in the wrist, and the pedal, which is in the foot. So these pulses are referred to as the peripheral pulses because they are farther out, which is peripheral on the body. So again, just to recap, so the pulses, your central pulses, are going to be your carotid and your femoral, and your peripheral pulses are your brachial, your radial, and your pedal because they're farther away from the heart. Here is locating the carotid pulse point in the neck. Here is the radial pulse point in the wrist. When assessing a patient's pulse, you must assess for these three characteristics: rate, strength, and rhythm. Pulse rate is a count of the number of beats per minute and is used to determine if the patient's pulse is normal, rapid, or slow. Strength is the force of the pulse. It will either be strong or it will be weak. And then rhythm is the steadiness of the pulse, which will be either regular or irregular. So when caring for a responsive patient, you can check the radial pulse at the patient's wrist. For an unresponsive patient, the carotid pulse in the neck should be used. The term radial refers to the radial artery found in the lateral portion of the forearm on the thumb side of the wrist. If, for any reason, you are unable to feel the radial pulse, you want to assess the carotid pulse. The absence of a radial pulse, when there is a carotid pulse, indicates an abnormally low blood pressure and possibly shock. A radial pulse may not be detectable if the patient's blood pressure is too low or if there is an extremity injury that is interrupting blood flow to that distal arm. For an adult patient, the normal range for the adults is between 60 and 100 beats per minute. Any rate above 100 for the resting patient is considered rapid, or what we call tachycardic. A rate below 60 may be considered abnormally slow or bradycardia. Some exceptions are well-conditioned athletes whose normal resting pulse may be about 50 beats per minute, or possibly even less. Or you might have that heart patient who is taking medication to slow his or her heart rate. So in emergency situations, because of anxiety or excitement, it is not unusual for the pulses to be above 100 beats per minute. With the infants, the primary pulse point for obtaining a pulse in the infants under the age of 1 year is the brachial pulse in the upper arm. This is due to the difficulty in isolating the radial and the carotid pulses given the underdeveloped anatomy of these small children. So to obtain a brachial pulse in an infant, you want to place your index and middle finger over the brachial artery on the inside of the baby's upper arm between the elbow and the armpit. You want to press gently with your fingers until you can feel the pulse. You may use the tip of your thumb on the opposite side of the arm to apply counterpressure. But be sure not to use the pad of your thumb because it may be possible for you to feel your own pulses there. With the capillary refill, it's a quickly released pressure. So you want to observe the color returning to the pad and document those findings. So to do a capillary refill, you want to push on your nail bed with your thumb. Once you release it, you'll notice that it's white right away, and as fast as that blood comes back, that's what they call the cap refill time. So if you push in the thumb and you release it and it stays white for 4 seconds, that would be considered a delayed cap refill time. That is, again, documentation that you want to note. So here's how you want to check for cap refill using the pad of the finger. With blood pressure is the measurement of the pressure of blood against the walls of the arteries, both when the heart beats and when it is at rest. So blood pressure and perfusion are closely related in that good perfusion that requires a good blood pressure. The lower the blood pressure drops below normal, the less effective perfusion really is. So a single blood pressure reading that is significantly above or below the normal range of the patient can be a valuable tool in determining the current state or condition of that patient. You want to repeat blood pressure measurements, which are the values of the trending of that patient's condition, and can also help identify changes in the patient's condition over time. So blood pressure is determined by measuring the pressure changes in the arteries. The pressure is generated when the heart contracts, is called systolic blood pressure. The systolic blood pressure is affected by many factors, such as the force of the heart's pumping action, the resistance and the elasticity of the arteries, blood volume, blood thickness, and the amount of other fluids within the cells. After the left ventricle of the heart contracts, it relaxes and refills. This relaxation phase is called the diastole. During diastole, the pressure in the arteries falls. When measured, this pressure is called the diastolic blood pressure. Blood pressure is measured in specific units called millimeters of mercury. These are the units on the blood pressure gauge. Because the system of measurement is standard for blood pressure readings, you will not have to say millimeters of mercury after each reading. Report the systolic pressure first and then the diastolic pressure, as in 120/80. The reading 120/80 is considered a normal blood pressure reading, which represents the average blood pressure obtained from a large sampling of healthy adults. There's a wide range of normal for adults and children. Blood pressures are not usually measured in the field for children under the age of 3 because it requires specialized equipment. You will know that the normal blood pressure for a patient, unless the individual is alert, knows the information and can tell you what it is. Because you will not know the normal reading for a particular patient, you will take several readings to identify a trend in the patient's condition. An initial measurement may show that the patient has a blood pressure within normal limits, but the condition may worsen. For example, a patient going into shock may have a rapid pulse and normal blood pressure reading when you first arrive on the scene. A few minutes later, the blood pressure may fall dramatically. Taking several readings while you're providing care is a way of identifying changes in the patient's status. Changes in the blood pressures are significant and let you know that additional care is needed and transport is a priority. For the typical adult, a systolic blood pressure reading below 100 should be considered lower than normal unless the patient tells you otherwise. However, some small adult females and small-build athletes may have normal blood pressures of 90. A systolic reading above 130 is typically considered high blood pressure and also referred to as hypertension. Many patients will show the initial rise in the blood pressure at the emergency scene. This is usually due to anxiety, fear, or stress caused by the incident and will return to normal once the situation or condition is under control. You will need more than one reading to confirm high blood pressure. High blood pressure readings are typically in individuals who are obese or who have a history of high cholesterol. There are many other underlying medical conditions that cause high blood pressure that you will be unable to determine at the scene. There are two common techniques used to measure blood pressure in emergency care. The first is by listening, which is called auscultation and requires the use of the stethoscope. The second is by feeling, which is called palpation. The palpation method will reveal only the systolic blood pressure. The auscultation method requires the use of the stethoscope to hear the sound of the blood pulsating through the artery. You must begin by adjusting the earpieces so they fit your ears properly. Hold the earpieces of the stethoscope between the thumb and index finger of each hand. Adjust the direction of the earpieces by gently turning them so each piece points slightly forward and away from you. This is to ensure that the opening of the earpieces points directly into your ear canals when placed in the ears and will help ensure that you will hear the pulsations once the blood pressure cuff is inflated. To determine blood pressure using a blood pressure cuff and a stethoscope, you should have the ill or injured individual sit or lie down. Cut away any or remove clothing that is on the arm, and support the arm at the level of the heart. Do not use the arm if there is any injury. Then you're going to select the size blood pressure cuff. The average adult cuff can accommodate an arm that is up to 13 inches in circumference. A cuff that is too small will produce falsely high readings. One that is too large will produce falsely low readings. You're then going to wrap the cuff around the individual's upper arm. The lower border of the cuff should be about 1 inch above the increase in the elbow. The center of the bladder inside the cuff must be placed over the brachial artery in the upper arm. So here's where you're adjusting the earpieces of the stethoscope so they point slightly forward and into the ear canal. Here you're checking for that proper position for taking a blood pressure while seated. And then in figure B, you're obtaining that blood pressure on that supine patient. You want to find the location of the brachial artery pulse point, and then get that proper placement of the blood pressure cuff. As you can see on the blood pressure cuff, it will show where that artery is, and then there's an arrow down. That's where the blood pressure is going to, the cuff is going to sit where the artery is. It'll point down to it. Then the pulse sounds will be heard through the stethoscope between the systolic and the diastolic readings. So here you will see that they place the cuff snugly around the patient's upper arm. Here you can see that they palpate the brachial pulse point and place the diaphragm of the stethoscope directly over the pulse point. You're going to quickly inflate the cuff and then release the pressure to obtain the blood pressure reading. You want to close the valve and inflate the cuff. I normally inflate it to 180, 200, depending on. Then you're going to open that valve slowly and release the pressure from that cuff. You're going to listen carefully as you watch that needle move and then let the cuff continue to deflate. Next, you're going to let the rest of the air out of the cuff quickly. Record the time, what arm you used, the position of the patient, and the pressure reading. Again, documenting your readings along with the time. So using the palpation method is that feeling of the pulse, which tends to not be as accurate as the auscultation method. It will provide you with one reading, which is an approximate systolic pressure. This method is used when there is too much ambient noise, making it difficult to hear with the stethoscope. So to determine the blood pressure by palpation, place the cuff in the same position on the arm as you would for the auscultation, and then proceed with the following. First, you're going to find the radial pulse on the arm with the cuff. Close the valve and inflate the cuff until you can no longer feel that pulse. Then you're going to continue to inflate the cuff to a point of 30 points above where the pulse disappeared. You're going to start to slowly deflate the cuff and note the reading when you feel that pulse return to the arm or wrist. This is considered the systolic blood pressure. You will not get a diastolic reading by palpation. You're then going to record the time, the arm used, the position of the individual, and the systolic blood pressure. Note that the reading was by palpation. If you give this information orally to someone, make sure that you say the reading was by palpation, as in blood pressure is 146 over palpation, or PALP. Here they have placed the cuff and located the radial pulse prior to inflating the cuff. Here's when they inflate the cuff until you feel the radial pulse go away. Here you're going to continue inflating the cuff to approximately 30 millimeters of mercury beyond where the pulse went away. So if the pulse went away at 130, you're going to increase it to 160. Here you're going to release the pressure in the cuff and note that the pressure in the gauge when the radial pulse returns. This will be approximately the systolic blood pressure. So if you note that the radial pulse returned at 120, that would be your approximate systolic blood pressure. Skin signs are often the easiest vital signs to assess because they do not require any special skill or equipment. The three characteristics you will be evaluating are color, temperature, and moisture. All three can be assessed by observing the patient's face and feeling the forehead. When assessing the skin color in light-skinned patients, observe the skin of the face, noting if it appears pink, which is normal, or if it is pale or flushed, which flushed is considered reddish, or if the skin is yellow, which is considered jaundice. In dark-skinned patients, observe the palms, nail beds, and the inside of the lips to look for the pink appearance. Skin that is not being perfused well will appear pale or cyanotic, which is that bluish color. Skin that is receiving an abnormal amount of blood flow might appear to be flushed or red. Skin that is yellow in appearance is said to be jaundiced and may be an indication of an underlying condition related to the liver. Next, you want to use the back of one hand to assess the skin temperature. And just note the back of your hand, not the palm, but the back. Pull the glove away from the back of your hand and hold your hand skin to skin against the patient's forehead. Be sure that you do not expose your ungloved hand to any patient body fluids as you do this. Note if the skin appears warm, that is normal, cool, or hot. At the same time you are assessing the temperature, you can assess for the moisture. Note if the skin appears to be dry, which is normal, or moist, which is sweaty. Moisture is also considered diaphoresis, which can be classified as mild, moderate, or severe diaphoresis. This condition of being sweaty is referred to as being diaphoretic. Some examples of skin signs would be pink, warm, and dry, pale, cool, and moist, flush, hot, and moist, or flush, hot, and dry. Here you can see that they're using the back of an ungloved hand to assess the skin temperature and moisture. To evaluate the skin color in dark-skinned patients, use one or more of these methods. The oral mucosa, which is inspecting the inside of the lower lip, this area should be pink and moist. Next, you can try the conjunctiva, which is the tissue on the inside of the skin that surrounds each eye. By simply pulling down gently on the lower eyelid, you will expose this area. It should be pink and moist. Next is the nail beds. This is the tissue that lies below each finger and toenail and can typically be seen through the nail. Of course, if the patient is wearing nail polish, this will not be an option. And next, the palms. The palms of the hands are generally lighter in color, regardless of the skin pigmentation. They are also full of capillaries, and a simple capillary refill test can provide some indication as to perfusion status in the hand. Whether you realize it or not, you have probably become quite good at assessing an individual's condition by looking into his or her eyes. Emotions such as fear, worry, anxiety, and pain can all be seen in the eyes. As the EMR, you will be able to assess the eyes for the following and very specific characteristics: pupil size, shape, and equality of the pupil size and the reactivity to light. So with size and shape, when you first look at the eyes, note their general condition and identify any obvious injury or deformity. Pay particular attention to the dark circles in the center of each eye known as the pupil. Note the size and shape of each pupil. Many EMS pen lights have a pupil gauge printed on the side to aid in the determination of that pupil size. You want to ensure that both pupils are round. Next is equality. You want to observe both pupils to ensure that they are the same size. Keep in mind that the dark-colored eyes are much more difficult to assess than lighter-colored eyes. It is also important to note that unequal pupils are a normal finding in some people. When you encounter a patient with unequal pupils, always ask if this is a normal condition for him or her. Next is the reactivity to light. One of the most important signs of good perfusion is pupils that respond briskly to the presence or absence of light. Pupils should respond to the sudden introduction of light by constricting, and in contrast should dilate when the light to the pupil is blocked. There are two methods that can be used to assess the pupil reaction, and each depends on the ambient light at the time. In a well-lit area, such as a bright room or on a bright sunny day, it may be of no use attempting to shine a light into someone's eyes. The pupil will likely already be constricted due to the large amount of ambient light. In this situation, you will have better results covering both eyes with your hands for several seconds, then observing the pupils constrict when you take your hands away. You must learn to be patient when using this method because it may take some time for the pupils to dilate after you cover the eyes. It is good practice to ask at least 2 or 3 questions pertaining to the patient's medical history while you're covering each eye. This will allow enough time for the pupil to dilate and not appear to be an awkward silence. An acronym that is widely used in EMS to help providers remember the characteristics of pupils is PERRL, P-E-R-R-L, which stands for P for pupils, E for equal, R for round, R for reactive, and L for light. As you can see here in figure A, those are constricted pupils, B is dilated pupils, and C is unequal pupils. In this section, we'll go over the summary of what we all learned. Good patient assessment is when you gather information or history about the patient and the chief complaint and obtaining complete and accurate vital signs. Properly introduce yourself and get the patient's name right away. Whenever possible, direct your questions to the patient rather than anybody else. Speak clearly and confirm that the patient hears, understands, and answers each question before asking another. Use the sample tool to help guide questions and always document the patient's answers. Obtain sets of vitals to establish a good baseline. You're going to repeat vital signs and compare to previous readings to establish trends in the patient's condition. Most vital signs have multiple characteristics, and you want to document those characteristics for each vital sign. You're going to assess the respirations for rate, depth, and ease. Assess pulses for rate and strength rhythm. Measure systolic and diastolic blood pressures, and assess the skin for color, temperature, and moisture. Assess the pupils for equality, shape, and reactivity to light.